All right, it's almost 5 after, so we're going to go ahead and get started. So Dr. James Snyder was supposed to be doing an introduction to diagnostic stewardship today, and he wasn't able to make it, so I threw together some slides this morning. I'm going to do a quick 10 to 15 minute introduction to diagnostic stewardship, and then Audry Hawkins is going to talk about blood cultures and kind of what happens after you order the blood cultures and those go into the lab. So let's just start off with what is diagnostic stewardship. So this area was more kind of firmly designated around 2017, but I think you'll see as we go through the quality improvement aspects of diagnostic stewardship have been going on longer than that. And I think what's important for this group to understand is this is really a core element as part of antimicrobial stewardship programs. So we talked about last month that antimicrobial stewardship programs are mandated now for hospital systems, and this is one of those core elements. So it's an important concept to be exposed to. So this diagram here shows and kind of defines a little bit of diagnostic stewardship. So it's really thinking about the ordering, the processing, and reporting of results. And then the antimicrobial stewardship goes hand in hand with that, because once you get those results, what we're hoping is that leads to some type of antimicrobial modification and a directed therapy. I think an easier way to think about this is, we spoke about antibiotic stewardship last month as being the right patient getting the right drug at the right dose by the right route for the right duration. Diagnostic stewardship mirrors that. Right? So we're talking about the right patient getting the right test at the right time, that once you get that test back is interpreted correctly, that leads to a therapeutic action. And then usually that therapeutic action is either going in and reevaluating your antibiotics, or sometimes it's stopping them altogether. So if we think about the process by which we see a patient, think about what type of test we want, and then how we use that test. You can see there's kind of major steps, right? We have to decide what to order. That test actually has to be collected by someone else that's usually not us. It needs to be processed by the lab, and then we need to get some type of report back that we actually interact with to make decisions, right? And so what are some ways in which diagnostic stewardship can improve care? So when we're ordering, I think we should be asking our question all the time, is this test necessary? When I get the result back, is it going to help me establish a diagnosis, or is it going to lead to some modification in treatment? If the answer is no, there's probably not a good reason to order that test, and maybe we shouldn't be ordering that test. But what are some interventions that can help us order more correctly? So this may vex us sometimes, but institutions may either remove, restrict, or modify how we can order certain tests, right? So if there's certain tests that are over-ordered that are very expensive, it very well may be restricted by your institution. Or they can just try to provide decision support. Sometimes that's a pop-up box or something else within the EMR that can help us. So an example of this is our syphilis testing. In the past, we would have to order a separate RPR and a treponemal-specific test, right? Now when you order it, that treponemal IgG automatically reflexes to the RPR. If that didn't happen, we'd get the test back and say, oh, could they have syphilis? Then we'd have to order the RPR. It would take more time. So by doing this and lumping these orders together, we're actually saving time and getting to our diagnostic criteria quicker. What about collection? Are the collection methods that we're using adequate to prevent contamination? So for infectious disease diagnostics, because our body basically has more bacterial cells than eukaryotic cells, this becomes a big issue, right? And we can think about how many blood cultures we have, and there's always that question, is this contamination or is this real? So what can we do to improve our collection methods? So we have institutional policies on how these specimens should be collected. Now, I think there's a question on whether they always happen that way, right? So when you're ordering a urine specimen in a patient with a Foley, is this being drawn from the Foley bag where it shouldn't? Or is it actually being drawn from the hub of the catheter? Is it a fresh catheter? Is it something that's been in a long time? So a diagnostic stewardship may be the team going and reviewing those orders and working with the people that are actually drawing the labs to make sure and provide education that they're done correctly. For the lab processing, are there things that the lab can do to improve our diagnostic accuracy? And so some of these are, like the syphilis testing, incorporating multi-step testing to improve our accuracy, right? So C. diff testing. At one point, a lot of institutions were just doing PCR tests for C. diff. The rates were sky high. When you coupled that with a second test, those rates became lower. And what we realized is that most of the time, if you're looking at just PCR, the presence of a bacteria or not, you can't really differentiate infection versus colonization. Same thing with our urine testing algorithm, right? You have to have some type of pyuria or other abnormality before you move on to culture. But we also can think about use of rapid diagnostics. So when we get our blood culture results and it's PCR positive for MEK-A, suggesting that there's MRSA there, that gets me to a point where I can de-escalate therapy and target therapy quicker than if I had to wait for the culture for 48 to 72 hours. What about reporting? Is there things that we can do to guide appropriate practice with each test result? And so historically, our microbiology or sensitivity data is one of these areas. At one point, all we got is a list of drugs and numbers, and we had to identify which ones were within the breakpoints. Then they started adding the S, the R, the I for susceptible, resistant, intermediate, and now we just give the letters. But they also are now providing additional information. If you get a coag-negative staph in your blood culture, there's going to be a comment. This may represent contamination. So this is all part of diagnostic stewardship, not overruling the physician, but at least trying to nudge them in the right direction. So let's take asymptomatic bacteria as a good example of stewardship interventions. So we've talked about this before. We'll continue to talk about it because it continues to be a big problem. So asymptomatic bacteria is culture of bacteria in the urine in the absence of signs or symptoms of infection, right? This is super common. Up to 60% of elderly patients, if you've had a catheter in more than 3 or 4 days, 100% of those catheters are going to become colonized. And this over-treating leads to a massive over-prescribing, but also a lot of adverse events. If they're on antibiotics, they're going to have longer hospital stays. You're going to have increased risk of C. diff infections and more side effects, right? So what are the diagnostic stewardship interventions? So I think if we think about this from a diagnostic stewardship perspective, what we realize is that over-treatment of that asymptomatic bacteria really is the result of inappropriate ordering of urine cultures. Because we know a lot of these cultures are going to become positive. So what can we do? Well, you can provide education or EMR prompts. When you put in that order, what are their symptoms? Is it appropriate to actually be getting the urinalysis? We can work on better culture collection techniques. This continues to be a problem, I'd say, in our hospital. What about processing in the lab? Well, right now, for the last couple of years, we've had a UA with a reflex culture, right? If you don't have pyuria, or if you have evidence of contamination, they're not necessarily going to do that culture. Now, unfortunately, with that, I'd like to have notifications sometimes of like, hey, this culture got thrown out because of this. That doesn't always happen, but I think there's room for improvement there. And then reporting, you know, you often see micro reports that say, oh, this has more than 3 organisms, likely contamination. So again, trying to nudge a really common problem towards improved outcomes. And does that work? So this is a paper from 2021 where they basically looked at their appropriate in gray and inappropriate in yellow antibiotic use related to urine testing before and after they put in a reflex system. And you can see there wasn't any change in appropriate antibiotics overall, but there was a really big decrease in inappropriate antibiotic prescription. And that's what we're really aiming for with a lot of these interventions. Now, when you do things like couple multiple tests together, we do get changes in the test characteristics, right? So our positive predictive value may go up because we're using those dual tests. But you will have some degree of a loss of specificity. So we are going to have to accept that we're going to miss some diagnoses sometimes. Now, I know that's worrisome because we never want to miss a diagnosis, but I think if you think about the sheer volume of these tests that we do, most of these tests, if we miss it, those patients are going to come back on that second test, they're going to become positive. So it's something we certainly need to consider when we do diagnostic stewardship. How are we changing that kind of balance in the test characteristics? So what are some other areas of major kind of diagnostic stewardship interventions? And not just, this is not necessarily at U of L, but really nationwide. And so you can see we have all of these different types of tests. We have point of care tests in infectious diseases. We have our microbiology test. We have kind of exploding next-gen sequencing and molecular analyses. But really, it's all of these tests like urine cultures, blood cultures, respiratory cultures, and C. diff, where we're having to make the distinction. I got a positive test, what does that mean? Is this an infection or is this colonization? And that's the hard part, and that's what probably me and my ID colleagues deal with the most, is helping people interpret these tests that get sent. Just a brief mention on molecular diagnostics. So if we think about the false positives that we get here, this is even going to make that higher, right? Because this is a more sensitive test. It's going to pick up anything that's present. So if you send this on something like urine, you're going to get multiple potential bugs, and it may not be that all of them are the problem. Maybe none of them are the problem. Maybe it's just one. It gets harder to interpret those results. So what are the benefits of diagnostic stewardship interventions? So our goal is to have a decrease in either overdiagnosis or our false positive rates, right? So if we think about things like catheter-associated UTI, catheter-associated bloodstream infection, and C. diff, these are all publicly reported metrics. They are linked to hospital reimbursement. So if we overdiagnose these, hospital revenue goes down, reputation goes down. So it's really important that we have a firm diagnosis and we don't have technology that overemphasizes the problems that may be present. This also, I think, an underappreciated is decreases the anchoring of wrong diagnoses, right? So how often do we have somebody in the hospital, oh, their culture is positive, that's what's wrong with them. 5 days later, they've been on antibiotics, they're not getting better, and we finally revisit their diagnosis and say, was this really the problem all along? So there's been several cases of patients with IBD who were undiagnosed that tested positive for C. diff, went through weeks and weeks of C. diff testing because they were having diarrhea, which delayed their ultimate diagnosis of IBD. You know, these patients are at higher risk of having C. diff colonization anyways, so it's easy to see how that would happen. You know, obviously, part of the stewardship program is we want to decrease unnecessary antibiotic use. And I think, you know, from an internal medicine standpoint, our goal that couples with that is decreasing hospital stay, decreasing side effects, and then decreasing cost. So here are some examples of different stewardship procedures from a paper that came out this year. And you can see it's not just the things like C. diff or UTIs that we've talked about, but even things like pulmonary embolism and the diagnosis of that, that if you can couple that with metrics, can we do things like decrease CT scan testing? That's big cost to the healthcare system and big cost to patients if we don't need it. So I want to leave with something called Choosing Wisely. This was an initiative started by the American Board of Internal Medicine back in 2013. And so basically it was a list, and they went to all of these subspecialty organizations and say, what are some practices that we should be avoiding to save patient side effects, to save patient cost? And again, it's really diagnostic stewardship in many cases, trying to couple that right test at the right time, interpret it right to therapeutic action. So these are the Infectious Disease Society of America, things that physicians and patients should question back from 2015. So don't treat asymptomatic bacteriuria. Avoid prescribing for antibiotics for upper respiratory infections, especially if they have a viral infection. You know, don't give antibiotics for stasis dermatitis, which isn't an infection to begin with. Don't test for C. diff if you don't have diarrhea. Avoid prophylactic antibiotics for mitral valve prolapse. So you can see several of these are things that we are still actively working on even 7-8 years later. So it's a problem because a lot of times we anchor and say, oh, I want to get the test just in case, to make me feel better. When I think we don't really recognize the fact that over-treating with antibiotics is not a zero-cost intervention, that there are risks associated with it. And so with that, I'm going to pass it over to Audrey and let her talk about blood cultures and some of the...
All right, thank you, Dr. Doster. So, as he mentioned, you saw on that slide there things like C. diff, diagnostic stewardship, upper respiratory cultures. There's a whole slew of things of diagnostic stewardship that become important. But one of the most unnerving things, right, is having your patient potentially be septic and you're waiting for those blood cultures to come back, and they come back and you don't know what to make of them, or you don't know what that process looks like, or you're waiting and you're waiting and you're waiting and you're trying to figure out what's going on with that blood culture and if you should raise some alarm bells. Well, that process is a little bit lengthier in explanation, and so that's why we wanted to talk about it today as a separate process. We'll talk about like UTI diagnostic stewardship and C. diff diagnostic stewardship throughout our discussions this year with our different disease states, but we decided that this determined it needed its own lecture. We're going to go over a few things today. So we're going to go over indications for blood culture ordering, because of course that is very important with diagnostic stewardship and getting a high yield result for your culture. We're going to do a brief review of gram staining. This is, as Dr. Snyder calls it, the most overutilized and abused test that we have. However, it's very efficient and quick. And then an overview of our blood culture process and what happens here in our ULH lab. So we are very, very grateful that we have Dr. Snyder here in our lab. He's brought some wonderful rapid diagnostics to our institution. However, if you don't know how those things work and you don't know how to interpret them, then they're not really worth the money. So that's what we're here doing, is trying to show you how to interpret these and to act faster. First, indications of blood cultures. How many times have you seen a patient that spikes a fever and they get blood cultures ordered? And then you're waiting, maybe you start antibiotics, you're waiting for those cultures to come back, although, you know, their fever subsided, you figured out it was something else, but now you're stuck with this 48-hour window of antibiotics because you're waiting for their blood cultures to come back. Well, these indications for blood cultures are really important, and again, highlighting the importance of pre-test probability and your patient's clinical scenario. So this was from a paper in 2020 called something along the lines of, does my patient need this blood culture, right? Very clear. And they break them up into high probability all the way down to low probability. So you can see here what's really coming into play is you want to make sure your patient has a clinical syndrome that makes you think sepsis, septic shock. Do they have something like discitis or vertebral osteomyelitis, where it's likely that that was a spread from the bloodstream infection to that site? Or do they have something that's a little bit less risky, like ventilator-associated pneumonia or cellulitis? They deem severe comorbidities is a little bit higher risk than you'll see in uncomplicated cellulitis. But cystitis, your patient shouldn't have a bacteremia from cystitis, right? So why would we get blood cultures if that was their presenting infection? Certainly happens, but you want to start thinking of things like pyelonephritis and taking that patient into consideration to see if they do meet indications for a blood culture order. There is a study that Dr. Snyder and some of the pathology fellows are working on, looking at clinical criteria for ordering blood cultures, and so far they have found that only 48% of our blood cultures that are ordered meet this diagnostic criteria. So over half of our blood cultures that we are ordering do not meet a clinical criteria. And I want to highlight again here that an isolated fever or a fever within 48 hours after surgery, those things are not standalone reasons to order blood cultures and can put you down this path of thinking infection when in reality it's something else. So repeat blood cultures is also something that comes up quite frequently, right? Do I need to get repeat blood cultures for this patient? Do they have an infection and I'm checking for clearance or I'm checking for improvement? And this is something that is also, aside from initial ordering of blood cultures, this is also something that gets overutilized. So I wanted to highlight the indications for ordering repeat blood cultures. These are concerned for endovascular infection. Does your patient have a device or something that would predispose them to an endovascular infection, in which you want to make sure that you have either gotten the source or you want to check for clearance and improvement in that endovascular infection? Staphylococcus aureus and Staphylococcus lugdunensis, these are two Staphylococcus species that are known to cause, they're very, very sticky, so they can have high rates of endocarditis, high rates of additional sequelae of infection. So there's a lot of data in these two specific bacteremias with repeat blood cultures and assessing for clearance and basing your therapy off of that. Of course, I always say, if your patient doesn't improve within 72 hours on the appropriate therapy, maybe we should start digging into something else. So maybe something else has come up, maybe their organism is now resistant. And so certainly in those patients that haven't deprivessed within that 72 hours, it's recommended to evaluate if you need repeat blood cultures. And then lastly, an unknown source or a source with a known difficult antimicrobial penetration. So these are things like abscesses, intra-abdominal infections, things that potentially you might have a harder time, prostatitis, getting your patient an antibiotic to that area. Blood cultures are technically not FDA approved for surveillance and test of cure. So just something to think about. These are not necessarily useful for test of cure. When we talk about gram-negative bacteremia and gram-positive bacteremias later in this year, we'll highlight the differences in those and the importance of repeat cultures and what happens when you do order repeat cultures inadvertently or not necessary. And so they really do lead to prolonged stays in the hospital, prolonged lengths of therapy, and adverse effects. So just keep that in mind when you're thinking, do I need to order repeat cultures? Is it going to be relevant to your patient? All right, so you ordered blood cultures, right? Now what happens? We're going to talk about this timeline. I think this timeline is one of the biggest questions that I get is, hey, we order these blood cultures. How long do we expect? What's going to happen in this situation? When should I expect a result? So I want to bring up this timeline for you. And again, this is specific to you, Abel, because of our wonderful rapid diagnostics that we have, but I'll try to compare as we go along. But first I want to ask, does anyone know how many blood culture bottles are in a set? What does this appropriate ordering look like for blood cultures at our institution?
2 bottles, 2 different sites, far away from each other. That's like 10 cc's of blood, I think.
Yeah, there you go. You got the whole slide.
Decent chunk of blood.
Yeah, so that was the whole slide. Great job, 100%. So the goal of this is you get 2 bottles per draw. You get an aerobic and an anaerobic. Those bottles look like hot sauce bottles, I think, personally. So what is in those bottles? Those bottles are specifically made for the technology that we have here. And it creates a perfect environment for either an aerobic or an anaerobic organism to survive, depending on the bottle. But it also has some things in there that help kind of break down the antimicrobials to help increase the rates of positivity. So we have a really cool technology here. But yes, you're right. So our power plan that we have is 1 anaerobic, 1 aerobic, and you'll get 2 sets of those. So that's 4 bottles, right? Like you said, 8 to 10 mLs each. So that's about 40 mLs of blood. And then within 8 hours, they want you to get another set. Does anyone know why we want this extra set? There's a few reasons, but I think one main big one. Contamination, did I hear that? So something that happens a lot is you'll see either a butterfly put in and they just pop onto blood culture bottles. Perfect, thank you. But have you ever looked at a needle, right? It's got a little circle and opening in it. You're essentially taking a skin punch biopsy of that patient every single time you're getting blood cultures. Well, that skin goes somewhere, and it usually goes into the blood culture bottle. And so by getting this extra blood culture set within 8 hours, so at a different time, this is why getting them from 2 different sites at 2 different times is so important, because you're really wanting to decide if this is a contamination or if this is a true bacteremia. There's also some data on persistent bacteremia or bacteremia that may not necessarily be like a transient bacteremia with this difference in timing, but really the contamination comes into play here. All right, so you got your blood culture bottles and they go into this massive refrigerator looking thing called the BD BackTech. So BD is a brand like tissue Kleenex. BackTech is the device. It stands about the height of a refrigerator. And what this does is tells you positivity. So this is really nice for our microtechs because they can pop these bottles in there, go about their day, and it'll pop positive. It'll ding positive when something has popped up. Before, they would just have to continuously monitor them for like growth, cloudiness. It could be a very, very lengthy process. So this is so nice. They can go through and do things throughout the day, and then it'll tell them if it's positive. And how this happens are in these hot sauce bottles, as I like to refer to them, there is a little resin disc. And when the bacteria start to grow, because they're in this perfect environment to grow, these bottles are really helping them ramp up and divide, they start to produce CO2, and that CO2 binds to the resin and puts off a fluorescence. And so this machine is going through looking for that fluorescence, and it'll ding and say, hey, you've got a positive bottle. It doesn't tell you what's in the bottle. It doesn't tell you anything about it. All it says is, hey, this one's positive. You should check it out. That takes about 8 to 12 hours. And something I want to highlight is that if you order a bacterial blood culture, they're only keeping these for 5 days and then they toss them out. If they're not positive, they're thrown. So if you're thinking something like maybe some endemic fungi, or you're looking for AFB, like tuberculosis for some reason, if that's in your blood, you would need to send those specific cultures so that denotes to them, or you need to call down and communicate with the lab, because if not, they'll throw these away after 5 days, and we know those things take a little bit longer to grow. So that's why we have the different sets of blood culture ordering, and really culture ordering altogether. And it takes about 8 to 12 hours. And what you'll see here is a theme of when we are requiring growth. We'll see a little bit longer time. So you have to think to yourself, I can't get a positive blood culture result until it has grown. Now we try to speed that growing up with the environment that we put them in, but it still is up to the organism to grow at that point. After you get a positive blood culture, they take it out of the BackTech and they'll perform a gram stain. Again, the quickest, easiest, most overutilized test that we have, and this is the first result that you will see. Based on that gram stain, they'll put it on the Verene panel that we're going to talk about. But really the gram stain is a very important part because I think there's a lot of misconceptions about a gram stain. I'm going to take it back to old school biology, microbiology in college. You can always tell where the gram stain sink is because it's pink, purple, it stains everything, right? But gram stain is a very quick process that is dependent on the cell wall of the organism. So that's how you get gram positive, gram negative organisms. Essentially what you do is you have your bacterial smear on the slide, so that blood culture is positive, they take it out, they smear it on the slide, and then they go through this dyeing process. What happens with this dyeing process is first you apply crystal violet stain, you let it sit. In gram-positive organisms, they have a very thick peptidoglycan layer that just gets saturated with that purple color and holds it. So when you try to counterstain it, wash it off, counterstain it with something else, that purple color holds. So that's why you get the purple color for a gram-positive organism. Now with gram-negatives, they have a much thinner peptidoglycan layer. It's very easily washed out and counterstained. And then this last step, the safranin, is a reddish pinkish color. That's why you get your gram-negative organisms being that color. And this is very easily visualized. You can see here, maybe 3 to 5 minutes. You look it under the microscope and you report what you see. And in a blood culture, they have 60 minutes from that blood culture being positive to call to the floor, to the nurse, that you have a positive blood culture with gram-positive cocci, gram-negative rods, whatever it may be. So now I have a pop quiz, and we'll have some fun here with some gram staining pictures. We just talked about what was gram-positive and what was gram-negative, but does anyone know on the top left, gram-positive, gram-negative, cocci, clusters, what does it look like? Staph aureus, yeah, we got 4. There we go. You guys just keep getting 100 initially. Yeah, gram-positive cocci and clusters, and that's what will be reported on your gram stain. So that's when you're starting to think, okay, what do I know is a gram-positive cocci and clusters? Staph aureus, you heard it. Staphylococcus species are gram-positive cocci and clusters. What about the one on the very bottom? What does that look like? Strep species, yeah, jumping the gun. Gram-positive cocci in pairs and chains is typically what it comes up as, and you're thinking strep species and Enterococcus species is typically in pairs. But they can give you a lot of really good information on that initial gram stain. And then of course, the top right, gram-negative rods, right? So these are things that we're thinking of, like E. coli, Klebsiella. Our microtechs are wonderful. Sometimes you'll call down there and they'll look and be like, this looks like Stantrophomonas, and they can just tell you right from looking at that gram stain, which is completely insane, but it is what they're trained to do. So based on this, they'll give you the gram stain. They have to do that within an hour. That's the call you get, right? You get the call about gram-positive cocci and clusters. You think, am I concerned? Is this contaminant? What do I think about this? And it's not until later that you actually get your result, but you don't get that call about the result, right? That's why we want to do this. That way you know when to check back and when to make those decisions. Again, that takes 5 minutes. First thing you see. Important thing, nothing actually grows on a gram stain. This has already grown, you're just seeing it. It's like if you went and spit on a plate, you could gram stain it and see everything that's in your mouth. It's not that it actually grew, it's just that you put it grew in the blood cultures, then you're gram staining to see it, and then it has to grow again. So there's still time after that that you'll have to wait for. This is how it shows up with Cerner. Weirdly enough, you may have noticed it falls to the bottom every time you get a result. So you have to scroll. I've been burned before of like an MRSA in the blood culture and I didn't scroll far enough and there was also a gram-negative rod. So just make sure you're scrolling down to see if your gram stain matches your final result. Been burned a few times on that. And based on this, this is how we decide which rapid diagnostic panel to put it on. And you're probably all thinking, maybe you've heard Verene. Have you guys heard Verene tossed around? Anyone familiar with it? Or familiar with any like blood culture technology? Okay, perfect, you're in the right spot. They'll put only the first bottle on Verene. So again, think you're getting 6 bottles per patient. All of those could pop positive, but we're not gonna run this like cool fancy test on every single blood culture that comes up. So what they'll do is they'll put the first one in and then they'll just do a gram stain on the rest to make sure they match. So if you see results that say like, oh, you know, molecular testing identified E. coli and then the rest are taking forever, that's why. They only did it on one. So they're just making sure that everything else is still showing up gram-negative rods, and then they'll get you that result later. what Verene is an automated multiplex molecular diagnostic test, which is a big name for a PCR-based test. So it's looking at the organism's DNA. It can rapidly identify genus, species, and genetic resistance, and it gives you the identification. So this is the next step, right? You've got a positive result, you've got your gram stain, now we're telling you what it is. Keep in mind, the Verene only has a few different targets that we'll talk about, but this genetic resistance is something that I really want to highlight. Does everyone here understand the difference between genotypic and phenotypic? So genotypic, right, is the genes that you have, and phenotypic is how you actually express them, right? Like, oh, I've got the genes for brown eyes, but I have blue eyes. So genetically, maybe I have brown eyes, but phenotypically I have blue eyes. And that's the difference between that. So this gives you only genotypic resistance mechanisms. It does not tell you the full resistance panel for that organism. This is the workflow, and this microtech does not actually work here, but I think it is important to say that there is room for human error in this. So this prints off a machine, they have to put it in. So again, once you feel like you understand this, if you're seeing anything wonky or seeing anything weird that maybe doesn't match up, definitely call down to them. There is room for human error in this. It's not all just robotic putting in from one place to another. Now these are gram-positive targets, so there's a gram-positive panel and a gram-negative panel. They will only put your organism on one of those panels. So if you have a gram-positive cocci on your gram stain, they'll put it on the gram-positive panel. They're not going to waste time on the gram-negative panel because it's not going to find anything. And I have had an instance where the gram stain said gram-negative rods, and I got a result of Staphylococcus aureus. I'm like, how did this happen? We shouldn't have even been on that panel, and it ended up being an incorrect result. And so that's why we want to teach you these things, so that you can kind of identify those things that could, lead you down a very drastic treatment difference, right? Vancomycin, which covers no gram negatives versus a gram negative agent. But you'll see here what it does is it goes down in a stepwise path. So let me see if I can get this. Yeah, there we go. So it'll start here at the genus level. So is it Staph, Strep, or Listeria? If it's one of these, then it'll move down here. Now you'll see we don't have any other Listeria species on here. That's because there's really only one clinically relevant Listeria species. I even know organizations that won't put gram-positive rods, which is what Listeria is, on their rapid diagnostics because the only real pertinent one is Listeria. And so in those patients, you should be able to identify those at risk for Listeria. But if it's Staph or Strep species, it'll then go down and say, okay, is it Staph aureus, Staph epi, Staph lugdunensis? Which streptococcus group is it? Or is it Enterococcus faecalis or Enterococcus faecium? You can see they don't even mess with Enterococcus species up here because they know the difference and the importance of knowing if it's faecalis or faecium. Faecalis, right, is our more susceptible but more virulent one, and then faecium being our less virulent but more resistant. So this is typically your VREs. We have less than 10% susceptibility at our U of L health system for vancomycin for Enterococcus faecium. I can go on why vancomycin is a terrible drug for Enterococcus, but we'll save that for another day. So if you're getting these results, right, you can make a very quick and easy de-escalation decision or escalation decision. And then from there it goes over and says, okay, well, based on this organism, do I have any resistance? So the MEK gene, the MEK-A gene, is coding for methicillin resistance. And this tells you, it's so nice, tells you right away, MRSA, MSSA. Immediately, you should have that result. And it goes down to VAN-A and VAN-B, which codes for vancomycin resistance to Enterococcus specifically, so you'll know if it's VRE or non-VRE immediately. So I always tell people, they'll say, oh, I'm waiting for it to tell me if it's, Staph aureus, methicillin resistant, or methicillin susceptible. You should know. And if you don't know, then there's an issue with the test or the report. So you will know right away what you're messing with here. Same thing happens for gram negatives, but you can see it's a very small panel compared to the gram positives. However, these are the majority of the bacteremias that we see. There are larger panels with different brands. We have evaluated some of them, but this is what we have right now. So again, it'll give you very high level Acinetobacter species, Citrobacter, Enterobacter, and Proteus species. These two kind of stink because we know there's some more resistant Enterobacter and Citrobacter than others, right? Citrobacter frendii, we know we don't want to use ceftriaxone, but maybe Citrobacter cosseri might be able to get away with it. And then of course, Enterobacter cloacae species are certainly something that we want to make sure we're using a more broad spectrum agent like cefepime for. Then it goes down to your species level, so E. coli, Klebsiella oxytoca, Klebsiella pneumoniae, and Pseudomonas aeruginosa. Again, tells you this right off the bat. But the cool thing and the important thing with this panel for gram negatives is the resistance mechanisms that it has. So So it has, what is that, 6 different resistance mechanisms, and it tells you it right off the bat. So CTXM codes for ESBL, right? So you know right off the bat, do I have an ESBL E. coli? Am I missing the buck? Am I missing the train on what I'm supposed to be using? These are carbapentamases, and so KPC is by far most common carbapentamas. And you can get some of these very resistant ones. So NDM, oxas, those are ones that, I mean, hopefully at this point you're calling ID because it can get pretty gnarly and trying to come up with treatment regimens for these people. But we actually got some great data at Jewish hospitals specifically, so don't take this and run with it, that are in patients with blood cultures who are CTXM negative, so no genetic resistance markers detected. There was 97% susceptibility to ceftriaxone in that patient population. So if you have that data available to you, then you're able to use these things in some other clinical scenarios with your patient, right? I want to make sure they haven't grown a resistant organism before, because this only picks up some of the resistance markers. Again, this is genotypic, not phenotypic. There are many ways that an organism can be resistant aside from this, but with that data, we did show very high susceptibility rates. And again, it tells you this right off the bat. So here you have a Klebsiella pneumoniae, no resistance markers detected. It will tell you if there are resistance markers detected. So you can feel more safe here in the right clinical scenario. And okay, I don't need something like meropenem. I shouldn't need something like ceftazidime avibactam or some of our bigger guns. You should feel more comfortable knowing that you probably have your patient on appropriate therapy if they're on one of our standard gram-negative agents. And this happens very quickly, yes.
Is there a way to know when they use the Verene in the cultures? Like, how would we know?
If they use a what?
How would we know that they use
Verene
in that culture? Because
yes.
sometimes, like, we don't know.
So your result will pop up much faster. So this result will take place about 2 hours from your positive blood culture. If it's not on Verene, it'll take significantly longer. And then it depends too. Sometimes they'll say like via molecular it's not consistent. But sometimes those results will say, you know, via molecular diagnostics, we were able to find this, or some verbiage of that. It'll also tell you if it was not identified on Verene, which we will go through as well. Another. Yeah, if you've got, so the question was if you had a gram-negative and a gram-positive in your gram stain, you would go through both. So they would put it on both of those panels. All right, any other questions before we move on from Verene process? Okay, and again, this is very, very quick. So here's an example of VRE being told to you right away. If you ever get a result that just says Enterococcus faecium, then that has not been designated as a VRE per the genes that they supply. Now, I think given our very, very low susceptibility rates to vancomycin, I always call and double check. So again, using some of your context clues, but it will tell you right off the bat. So here we are, you've got your patient who is sitting at what, maybe 15 hours max after getting their blood culture, and you know that they have a positive blood culture, and it's likely you know the species and potential susceptibility of your organism. So it's really, really very rapid when we compare it to some of our older methods. If it's not identified on Verene, I think like we said, you know, there's only so many targets it can hit. If it's not, this is what pops up. Unable to identify by molecular technology. This does not mean it's a more resistant organism. This does not mean that it is not an important organism. It just means it wasn't one of those targets. Important organisms that are not on there, Serratia, Morganella, Salmonella, right? So there are a ton of organisms that are not on there. I mean, there are thousands upon millions of organisms. And so that's all that means, is that you're just gonna have to wait a little bit longer. When this does happen, we do have to move to some of our more traditional microbiology techniques. So that's when they take the organism, they plate it, they wait for it to grow in the agar. Again, throwing it back to your very early microbiology and biology days. And that takes about 12 hours. So again, you're waiting for this time to growth. Now you're kind of stuck with seeing what the organism does. Sometimes it doesn't grow. There are certain strep species that just don't do great in the lab unless you put them on the right agar in the right environment, give them the right nutrients. So there are times that you might have a positive blood culture and then nothing grows, depending upon what the organism is. After it grows, we put it on something called MALDI-TOF. Has anyone heard of MALDI-TOF? It is a wonderful tool, and it's why you see all the weird bugs that you've never heard of before. So MALDI is like yay high, sits on a countertop, so a little bit smaller, but it's mass spectrometry. And so what it's doing is it's measuring the mass of that organism as it's flying through. They had a very, very simple acronym. I like to think of it, they were very creative. But it has a much wider array, so they have a huge catalog of organisms that they can identify, and this is how they identify anything not on Verene. This is how they identify most of your other cultures that you're sending, like respiratory cultures, urine cultures. They're letting them grow and then putting it on here so that they can identify it. The test itself is like 5 minutes. It does not take long for them to figure out what it is. You just gotta wait to get a good sample from that organism growth. And again, this takes about 12 hours or so, just due to the time you have to wait for it to grow. I'm gonna kind of move quickly through this because we're already at 2 p.m. from what I can see at the top here. Is that accurate? No, 15 minutes. Okay, this clock is a little fast. I got nervous. So what do we do with this, right? So you get all this information fast, but like I said, if you're not acting fast, is that really helping you? And has that been shown to improve anything? Like, do we just have these cool fancy toys, or can we actually do anything with them? And this is from Verene. So as you can see, as you would expect, Verene has a much quicker time to results and identification of your organism compared to your traditional blood culture workflow. So you're looking at like 15 hours here versus 48 hours here for your results of what your patient even has. They have also looked at it with stewardship interventions, antimicrobial stewardship interventions. So this was a study in 2016, and what they looked at was their control, so their traditional microbiology techniques. Then they looked at just having a stewardship program interact with those techniques, and then they added the BCID. So you can see here, if you kind of put all the shapes together, for organism identification, much faster with BCID, right? We know we have a much shorter time. Blood culture positivity, not really any different. But when you start looking at this effective therapy and de-escalation, you can see here that effective therapy, and this is the rapid technology mixed with your antimicrobial stewardship program, responding to that and making recommendations based on it. Time to appropriate therapy, 5 hours compared to 15 hours and 13 hours. If you're looking at antimicrobial de-escalation, you're looking at a 48-hour window instead of almost 60 hours in the other two. So this is why we as a stewardship program and as a stewardship team respond to your blood cultures. We send you these text messages, these email, page you, whatever it may be. Hey, your blood culture came back positive. What do you want to do with this? Because you don't get that call, right? It's up to you to go back into the patient's chart and evaluate if their blood culture was positive and what came out of that. And I think this is one of the biggest gaps that we see is, okay, they were called, 4 hours ago about their blood culture being positive. Well, they're on ceftriaxone and azithromycin for CAP. They didn't make any changes, but 4 hours ago it came back as MRSA. No one's done anything because you didn't get a call. And that's why we're here to help bridge that time between then. They also looked at it had any improvements in morbidity and mortality. And so again, this is rapid diagnostics with antimicrobial stewardship interventions. And you can see here in this forest plot that it is trending towards the better morbidity and better mortality with rapid diagnostics paired with an antimicrobial stewardship intervention. This was a huge systemic analysis, systemic review of multiple different studies. You can see spanning all the way from 2006 up to when this was published in 2017. So it certainly can have impacts in your patients. It also affects adverse events. So this was a study, again, that was done in 2019, looking specifically at, okay, I've got a patient with a gram-negative bacteremia identified on rapid technology, and I know it's not Pseudomonas. If I de-escalate them off of that anti-Pseudomonal within 48 hours is what they used, does that make a difference in C. diff rates? And it drastically did. You can see here the difference between more than 48 hours and less than 48 hours is about 2% to 7%. That's a huge decrease in C. diff rates. So that's why we know, again, every dose matters, every day matters, every intervention matters in these patient populations. What can you do? I think the biggest takeaway from this is if you see a new result, communicate it. You might be the first one to see it. Maybe you're not taking care of that patient that day. It's one of your colleagues. Hey, just shoot them a text. Hey, did you see that blood culture result come back? Because you can make such quick decisions on it only if you see it. Ensure your anti-infectives will cover your initial result. I always say I'm not mad at anyone for starting big and then narrowing down, having a plan to narrow down. Once you get these results, which will happen quite quickly, as long as you have a plan to target your therapy, you should be good to go. And then make decisions based on it. Utilize these tools to their utmost importance and know what tools you have, because if you go somewhere different, they might have something different, or we might make changes. And of course, you can call us if you have any questions. And that essentially takes an additional 12 hours of MALDI-TOF, but now you're looking at, 8 to 12 hours, 2.5 hours, so 15 versus 24 hours, right, with rapid diagnostics, so half a day's difference in your patient's treatments. Okay, I'm going to move on to T2 and I'm going to try to go through this pretty quickly. Has anyone heard of T2, utilized T2? Do we feel comfortable with T2? Do we know what it is? Okay, T2 is different than blood cultures. T2 is unique. T2 is expensive. So it is one of our diagnostic stewardship interventions that it is restricted and there are only certain patient populations in which you can order it because there's only certain patient populations that it actually helps. It's magnetic resonance for whole blood samples. So think like magnetic resonance MRI technology, right? But this is in cellular DNA. It's really cool. It's really novel. But it can identify organisms on this targeted panel. So here you've got 5 bacterial species and 5 different Candida species within 3 to 5 hours. You're not waiting for your blood culture to become positive. It is initially 3 to 5 hours. Is it there? Is it not there? It's restricted here at U of L to ICU patients. I think of this as something, it's a screen for your patients, right? It's a screen for what empiric antimicrobials should I have this patient on. So in patients in septic shock or our solid organ transplant oncology patient population, our immunocompromised patients. It has to be ordered with blood cultures. So again, it's a screen. If you're not pairing that with blood cultures, you're not going to get your confirmation or not. It's really meant to bridge that gap of negative blood cultures, but you need to have those blood cultures with it to compare. And it shouldn't be repeated within 72 hours, and it shouldn't be repeated for test of cure. So you should not be repeating these to see, oh, okay, well, my T2 was positive 3 days ago. Is it negative now? Am I doing the right thing? That's not what this is for. Again, this is a screen to get your patient on the right drug or to get them off the wrong one. What do you make of the results? I think these are some big questions that we have. Okay, well, my T2 is positive, but my blood culture was negative. Yeah, that's the point. That's the reason we do T2, right? Your blood cultures can be impacted by things like antimicrobials, poor blood draws, but your T2 is not impacted by antimicrobials. So you can have a patient on antimicrobials, and let's say they're not getting better. You want to see if something else is happening. Their blood cultures have never been positive. Well, if you hadn't initially ordered a T2, you can order a T2 and get that screen back, and potentially could show you if you're missing an organism or not. The big piece, or the big part that comes into play with this is the Candida T2s. And so they recommend in immunocompromised patients that if you have a patient who is not improving on antibacterial therapy, well, we know sometimes that those fungi or molds or what be it, specifically the Candida, can be difficult to grow on blood cultures, but you can get a T2 and it'll tell you if there's even a small level of Candida there. Wonderful tool. Please don't overuse it. We don't want to have to restrict it more. So just understand the ins and outs of it. It has a very high negative predictive value. The positive predictive value is not as high. I think some things that come into play here is there's up to a 10% false positivity rate with Candida. So we could probably test everyone in the room here and somebody would have a positive T2 for Candida, but looking around, it doesn't look like anyone's fungemic. So I don't know. I mean, maybe somebody's like sweating and I can't see it. But you just have to keep that in mind. Use it in your clinical scenario. Don't use it as your make or break. You know how to order that? You order it with blood culture. So when you go into blood culture, you just type in T2. But again, restrict. I wouldn't do it on your floor patients. Yeah, we got a question back here.
Oh, here's an ordering question for T2. So like ICU patients, I'm pre-rounding in the morning with my residents or my interns, and I'm like, oh, I need to order blood cultures on this person. And then we round, and then it's 10 a.m. and we're like, oh, now we need to order a T2 because I didn't think of that pre-rounding in the morning. I now have to reorder blood cultures so the T2 won't be done. So it's another, you're not even going to know, but Devin's not going to guess.
The policy technically states that you can add on.
So here they want the blood culture taken at the same time with the T2. Right?
Yes.
Same. But is that needed? Because if you already drew the blood culture like maybe 30 minutes before, you know, it's like you still have to get a whole nother set of cultures.
So the issue with the T2 is the modality in which it's ran. So it needs its own special bottles, it needs its own special draw, right? So that can be different. So you can't necessarily just like use your blood culture bottle and go for it. Now our policy technically states you can add it on. The logistics of that is where it gets kind of funky because like you're saying, like we're both saying, you know, you can't necessarily do that. But yeah, I mean, the whole point of it is to compare it to that blood culture. So in theory, you should be getting those blood cultures at the same time because something could have happened. You could have had a transient bacterium. You know, there could be a lot of things that play into that. We talk a lot about it when we do vent dosing as well. It's just what can you know, you want them to be on essentially the same curve. You want the same sample. And so while it's frustrating to get those additional blood cultures. Technically for the T2, you should be getting blood cultures concomitantly with the T2. Now, do you have to get all 3 or all 4 of those blood cultures? Probably not, because for the utilization of determining transient bacteremia, persistent bacteremia, colonization versus contamination, right? You've got those ones from earlier, so maybe you can narrow it down and get like just 2 of them instead of the 3 or the 4, but you should still be getting them with the T2.
Make a whole lot of sense to me. Like, if we're all playing a game with like probabilities here, right? Wouldn't it make sense that like the likelihood that something obscure happens within that 2 hours is probably relatively low? Because like these are all sensitivities with specificities that are pretty high. Likelihood that something happens within a couple hours. It should be able to be added on, and then we can interpret those results with understanding that okay, that could have happened, but most likely you can still help de-escalate stuff versus having to book your patients, get more labs, do all this stuff. Some people, it does bother them.
You know what I think the problem is? That they need a different sample for the T2.
Yeah.
Right,
But
but
they
cannot
can
use
get the T2.
that blood culture that was already taken and already put in.
Right,
the-
no, what
they
I'm
can get
asking
the
is, can we
T2.
just draw the T2 in the specific bottle? If you've already drawn all the blood cultures.
But you're throwing the blood cultures in their own bottles, right? Yeah, you've already.
But you're saying go back and just redraw only the T2 with the small amount of blood that it needs. So the issue with that is lab, right? Like getting those drawn at an appropriate time. If you could assure that you could go in and draw them within 30 minutes of that blood culture being drawn, sure. But with our phlebotomy shortage right now, the window expands from, yeah, sure, it should be 2 hours, but now it's 4 to 6 hours. Our policy does state that you can add them on. You can add them on as an order, and they should go get them. I reviewed it this morning, so you can like actually go and add them on. It's just the logistics of that, and if you did have something you wanted to call down, always what I would do, call the microlab, say, hey, I got these blood cultures 30 minutes ago, now I want a T2. Is it okay if I just go ahead and do that, or what do you need from me? Because you don't want it to get inconsistent, and maybe you have one person that says you can't and one person says you can. Now you've wasted all this time, all this energy. So technically policy says you can add them on. The logistics of that is where it comes into maybe not really sure how that's going to play out.
So the unit nurses will straw labs.
Mm-hmm.
But then they don't get process. So sorry. Because we have a lot of questions and consults about this, and I've experienced this several times. Even though you can add it on, you can do it like technically in like the EMR, but then you won't get the results because the technicians will get the order, they'll get the sample probably, but then they don't have a matching blood culture and they won't process it.
Yeah, that's part of their lab policy.
Who's considered an oncology patient? Is it just BMT? Is it active chemo?
Technically in our policy, it is patients who are immunosuppressed, like on our oncology units. It's not necessarily restricted to certain services. Like it's not that an oncology provider only could order it, but you would want to think patients like BMT, undergoing chemo. It's broad for our oncology patients. Any other questions about T2 before we move on? All right. I'm going to move through susceptibilities. So this is an intro to susceptibility testing. We'll kind of go through it very quickly, but this is why you have to wait for susceptibilities, right? You get your organism, you're wondering how long it's going to take until you get your susceptibility result. There's 3 main ways we do susceptibility. So there's disk diffusion, e-test, and broth microlution. I'll go through each of these. They're all important in their own ways. So the first is disk diffusion. This is like the poster child, I feel like, of susceptibility testing. So you imagine this big auger, you've got different impregnated discs of antimicrobials. So there's very standard antimicrobials they use in the lab that are not necessarily things we use in clinical practice. In vitro, certainly different than in vivo. So keep that in mind. But it gives you this zone of inhibition. So you're looking for an inhibition of growth around that disc. You can see here there is no inhibition zone around this disc. That one is probably going to be deemed resistant, even without me measuring how many millimeters apart that is. This one has a larger zone of inhibition. These are all different for the different antimicrobials and the different organism that you're testing. So there are standards, and looking at those distances from the disc and seeing how far they are and if that goes to a susceptible, intermediate, or resistant result. And it only gives you that. They don't give you the numbers. They don't tell you how far apart the zones of inhibition are. For this test specifically, we only give you a result, like the interpretation. We do this on most of our Pseudomonas because it messes with some of our other technology that we have. Cystic fibrosis patients, just because of the stickiness of the organisms that they grow, doesn't always do well in our automated susceptibility testing. The next is an e-test. So if you're ever calling down to the lab and saying, hey, I want you to check susceptibility for this specific agent, this is what they're doing. So they keep these on hands for our broad spectrum agents like cefiderocol, if you've ever heard of that, that's an e-test. Doxycycline is not on our standard panel, so you have to ask them to put an e-test, which is a lot of times not necessary because you can infer certain susceptibilities based on the ones that they actually run. It's all very standard. And this actually gives you an MIC. And so what an MIC is, the minimum inhibitory concentration. This is the number that you can see, but we don't report them. Has anyone ever been anywhere where they do report them? Okay. The reason we don't report them is because we don't want people going through, it's another diagnostic stewardship, and saying, oh, that one says 2, that must be the best one compared to one that says 4. It doesn't matter relative to the other agents that are on there. Comparing them doesn't make a difference. What you need to do is you need to just review the interpretation of susceptible, intermediate, and resistant and ignore that MIC result. Sometimes the ID group will go through and request those MICs because there are certain instances in which you can overcome that with dosing at higher levels. So you might every now and then see one release, and it's likely that we were trying to evaluate it to see if we could overcome that. And then this is an example of that. So you can see here that ertapenem says greater than 1, and imipenem and meropenem say 8, but ertapenem doesn't even work for Pseudomonas aeruginosa, typically speaking. So even though that number is lower, it would be a terrible option for Pseudomonas. All right, those take about 18 to 24 hours. Again, you gotta wait for the growth, you have to wait for them to react to the antimicrobials and for that to be read. The next is broth microlution. This is the fun one, I think. This is the standard in most laboratories, what most automated susceptibility testing models do. And what you're seeing here is a 96 well plate. Each of those wells have different concentrations of antimicrobials in them, and then you're inoculating each of those wells with a certain number or certain concentration of organisms. And so they'll read it, and it depends on the type of plate. Sometimes they're looking for fogginess, sometimes they're looking for fluorescence or color changes. And so that's how you can tell. You're basically looking, saying, okay, foggy, 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 clear, that's your MIC. This is what we have here. It's our automated method for susceptibility testing. It's called Microscan. This one's fun because it's looking at fluorescence, so it's looking at color changes. It will read that panel and then spit out a report for the microbiology text. Based on that report, they'll run additional tests if needed, but it's very, very quick and it's very useful. So you do have to wait for the organisms to grow in there, but it's nice because you can just put them in and then it'll tell you when everything is done. Again, that takes about 15 to 20 hours. So you'll get your organ. I always say it's good to estimate like 48 hours for a full panel result of your blood cultures if it's picked up on Verene and if it's getting on the microscan, if they're able to do susceptibilities on that and you're not looking for anything funny. Sometimes we have to send things out and they can take days, weeks, months, depends on the organism, but usually looking at 15 to 20 hours for the susceptibility testing after you get your result. This is how it looks. You might notice something like here, the VRE, you can see the drug of choice for VRE is dapto and linezolid, right? We don't report it, which is not on purpose. Some of our IT things are moving very slowly through the microlab because they unfortunately only have one person that does all of this. So in theory, this is called cascading reporting. So what would happen is if you have a VRE, so this vancomycin was resistant, it would then automatically go and show you dapto and linezolid, right? That makes sense, that's cool, we can use technology. Doesn't currently work that well. So if you ever have an organism and it's like, oh my gosh, it looks completely resistant, or this doesn't make sense to me, it says ceftriaxone resistant and then drops down to Bactrim and doesn't give me like cefepime, meropenem, it's on there, I promise. It's just that they have to go in and release that for you. So if you ever have any questions, again, reach out to the pharmacist on your team. They're able to look through one of our auxiliary programs that we use, and they can also call the microlab for you to get that taken care of. Your total time, again, like I said, I usually go for 40 to 48 hours. Trying to conclude very quickly here because we're already past time. I don't want to keep you guys too long. Use your tools to their utmost potential, right? You spend time learning about these things. Know what the test you're ordering does. Know how to interpret that result and know how it's supposed to show so that you can tell if there's something wrong with that result or not. Understanding the microbiology process is important for antimicrobial stewardship. So like I said, we get a ton of these questions. Hey, what does this mean? What does this mean? Is this important? Is this not important? And so trying to understand those processes are super important. And the micro lab loves to help you guys make decisions. They can help provide supplemental information to you. And if you talk to Dr. Snyder on the phone, he's really great at talking you off a ledge or talking you up onto one. And so if you are ever interested in, hey, I'm not sure what to do with this sample, should I get susceptibilities? Do we test this or do we treat this? You know, what do we do with it? He provides wonderful advice from the microbiology standpoint. And here's your ID pharmacist contacts. We have a new one at Jewish Hospital. We're very excited for Carly. And so you have Ashley and Julie that are here at U of L. Me and Carly are for every other site. And so if you're ever anywhere, this is how you get a hold of us, and we're more than happy to help. Again, kind of speeding through that last part there. So if there are any questions, I can definitely hang around and answer them for you.